Hello, my name is Gianella LaTorre, and this is my colleague Henna Patel. Today, we're going to be discussing Guillain-Barre syndrome.
To break down the history, we will start by talking about the French physician Jean-Baptiste Octave Landry, first describing the disorder in 1859. In 1960, Georges Guillain, Jean-Alexandre Barre, and André Stoll diagnosed two soldiers with the illness and described the key diagnostic abnormalities, which included albumocytological dissociation of increased spinal fluid protein concentration and a normal cell count. The Canadian neurologist C. Miller Fisher described the variant that bears his name in 1956. British neurologist Edwin Bickerstaff, based in Birmingham, described the brainstem's encephalitis type in 1951 with Philip Cloke, and further made contributions with another paper in 1957. Guillain had reported on some of these features before their full description in 1938. Further subtypes have been described since then, such as the form of featuring pure ataxia and the type causing pharyngeal cervical brachial weakness.
So, a brief introduction in terms of Guillain-Barre syndrome. So, what it is, it's basically a rare syndrome in which the body's immune system will attack part of the peripheral nervous system. So, as we know, the peripheral nervous system will carry signals from the brain to the muscles. Symptoms of Guillain-Barre syndrome can include muscle weakness, numbness, tingling sensations, which can also increase in intensity until the muscles can't be used at all, known as paralysis. The exact cause of Guillain-Barre syndrome is unknown. In most cases, it can occur a few days or a few weeks after symptoms of a viral infection. In rare cases, Guillain-Barre can run in families, and a diagnosis of Guillain-Barre syndrome is suspected when a person has symptoms suggestive of the syndrome. So, a variety of tests, including a spinal tap, can be completed to confirm a diagnosis. The most common type of Guillain-Barre syndrome seen in the United States is known as acute inflammatory demyelinating polyneuropathy, also known as AIDP for short. So, in AIDP, the immune response will damage the myelin coating and interfere with the transmission of nerve signals. In two other types of Guillain-Barre syndrome, there's acute motor axonal neuropathy, or AMAN, and acute motor sensory axonal neuropathy, AMSAN. So the axons themselves are damaged here by the immune response. Lastly, there's another one known as Miller-Fisher syndrome, which is a rare acquired nerve disease that is a variant of the Guillain-Barre syndrome, and it's characterized by abnormal muscle coordination with poor balance and clumsiness in walking, weakness or paralysis of the eye muscles, and absence of the tendon reflexes. Also, it's important to note that for the Miller-Fisher syndrome, it's very similar to Guillain-Barre in the sense that symptoms may follow a viral illness. So additional symptoms for Miller-Fisher syndrome could include generalized muscle weakness and respiratory failure. And what's unique about this syndrome is that they have a unique antibody that will characterize the disorder for a patient who is suffering from that.
So to sum up the previous slide, here are the 5 subtypes described. First, we will begin by describing the acute inflammatory demyelinating polyneuropathy. Its main clinical features include a sensory motor GBS, often combined with cranial nerve deficits and frequent autonomic dysfunction. And the key findings will be a demyelinating polyneuropathy. The antibodies vary throughout this subtype. In the next subtype, we will talk about acute motor axonal neuropathy, shortened as AMAN, and its main features include pure motor GBS. Cranial nerves are actually rarely affected, and we usually find this as axonal polyneuropathy, and sensory action potentials are usually normal. The antibodies associated with this subtype include GM1A, 1B, 1DA, GAL-NAC, and GAL-GD1A. The acute motor sensory axonal neuropathy, AMSAN, resembles severe AMAN, but sensory fibers are affected, leading to sensory deficits. And you will usually find an axonal polyneuropathy. Sensory action potential is either reduced or absent, and it will include the antibodies G1 and GD1A. The pharyngeal cervical brachial variant includes prominent weakness of the oral pharyngeal, the facial, the neck, and the shoulder muscles. And it's normal in most patients. Sometimes abnormalities occur in the arms, but it's mostly in an axonal pattern. And it will include the antibodies GT1A, GQ1B, GD1A, and in the final type, the Miller-Fisher syndrome, we usually find ataxia, ophthalmoplegia, and areflexia. And it's normal in most patients. There are usually discrete changes in your sensory conduction or H reflex, which may be present, and it will include the antibodies GQ1B, GT1A. And then a little fun fact we have is that the turtle symbolizes determination, persistence, patience, and understanding. This reptile is a slow-moving creature on Earth, but incredibly fast and agile in the water. And the turtle can teach us to stay grounded even in moments of disturbance and chaos. Next slide, please. So now to go over the etiology, we have the exact cause of GBS, which is not known. Researchers are not sure why it strikes some people and not others, and it is not contagious nor is it inherited. What they do know, however, is that an affected person's immune system begins to attack the body itself. It is thought that at least in some cases, this immune attack is initiated to fight an infection, and some chemicals on infecting bacteria and viruses resemble those of nerve cells, in which in turn also become targets of attack. Since the body's own immune system does the damage, GBS is also classified as an autoimmune disease. In Guillain-Barre syndrome, however, the immune system mistakenly will attack the healthy nerves. And in most cases, it'll usually start a few days or weeks following a respiratory or gastrointestinal viral infection. These infections can be caused by viruses such as the cytomegalovirus, Epstein-Barr virus, flu, or Zika, and from bacteria like Campylobacter jejuni. However, only a small number of people who have these infections develop GBS. In rare cases, vaccinations may also increase one's chance of getting GBS. And recently, some countries worldwide reported an increased incidence of GBS following the infection with Zika virus. So Campylobacter is one of the most common bacterial causes of diarrhea in the United States, and it's also the most common risk factor for Guillain-Barre syndrome. Campylobacter is also found in undercooked fish, especially poultry, and specifically your immune system of people with GBS will target the nerves in the peripheral nervous system, and these nerves are a part of the system that is outside the brain and the spinal cord. So it'll be responsible for carrying the signals out from the brain to the muscles of the body. And when your immune system attacks these peripheral nervous system, the signals will not be sent from the brain to the muscle, and they will as quickly as they should be, and they will lead to symptoms associated with the disease.
In terms of epidemiology regarding GBS, so it will occur throughout the world with a median annual incidence of 1.3 cases per population of 100,000, with men being more frequently affected than women. So in the AMAN one, so the acute motor axonal neuropathy form of Guillain-Barre syndrome, the infecting organisms probably share homologous epitopes to a component of the peripheral nerves known as molecular mimicry, leading to the immune responses cross-reacting with the nerves, causing axonal degeneration. The target molecules in AMAN are likely to be gangliosides GM1, GM1B, GD1A, and GAL-NAC through GD1A, expressed on the motor axonema. So, in the acute inflammatory demyelinating polyneuropathy form of GBS, the immune system will react against the target epitopes in Schwann cells or in myelin, resulting in the demyelination. However, the exact target molecules in the case of AIDP have not been identified. AIDP is also by far the most common form of GBS in Europe and North America, whereas the cases of the acute motor axonal neuropathy occur more frequently in areas such as China and Japan. The prognosis of GBS is generally favorable, but it is a serious disease with a mortality of approximately 10%, and approximately 20% of patients are left with severe disability. And it's also important to note that as a whole, Guillain-Barre syndrome is extremely rare, affecting only about 1 in 100,000 Americans, according to the National Institute of Neurological Disorders and Strokes. Signs and symptoms for Guillain-Barre syndrome will include nerves in the peripheral nervous system connecting to the brain and muscle will have trouble receiving and transmitting signals to the muscles. So the muscles won't be able to respond to the signals they're receiving from the brain if the nerves are damaged. So the first symptom that you'll see is usually a tingling sensation in your toes, your feet, and your legs, and the tingling will spread upwards to your arms and fingers. And the symptoms can progress very rapidly, and in some cases, the disease can become serious in just a few hours. So, symptoms of Guillain-Barre include the tingling and prickling sensations, like I mentioned, muscle weakness in your legs that travel to your upper body and get worse over time, difficulty walking steadily, difficulty moving your eyes or your face, talking, chewing, or swallowing, severe lower back pain, loss of bladder control, fast heart rate, difficulty breathing, and paralysis. And lastly, in the photo to the right, you're seeing how the signal can move through a healthy nerve, and that's normal, obviously. But when you have some sort of damaged nerve, like in Guillain-Barre, you see how the signal isn't able to be going through, it's interrupted.
So, as my partner mentioned, weakness and tingling in your extremities are usually the first signs and symptoms of Guillain-Barre. Guillain-Barre is a rare disorder in which your body's immune system will attack your nerves. And some other signs and clinical manifestations we find include limb weakness, difficulty swallowing, shortness of breath, and flaccid paralysis. And on the side, we can see a healthy nerve versus an affected nerve. In the healthy nerve, you see the myelin and the nerve tissue is all intact, but in the affected nerve, you can see the damaged myelin and the exposed nerve fiber, which leads to the signals getting interrupted. And then in the next slide, we have the diagnosis, which includes intracranial and spinal cord abnormalities, which are brainstem encephalitis, meningitis, lymphocytomatosis, transverse myelitis, and cord compression. The anterior horn will have cellular abnormalities, including polymyelitis and West Nile virus. Spinal nerve root abnormalities include compression, inflammation from something like cytomegalovirus, and leptomeningeal malignancies. Your peripheral nerves will have abnormalities that include some things like chronic inflammatory demyelinating polyneuropathy, so CIDP, drug-induced neuropathy, polyphyria, critical illnesses, polynephropathy, vasculitis, diphtheria, vitamin B1 deficiency, known as beriberi, heavy metal or drug intoxication, tick paralysis, metabolic disturbances like hypokalemia, hypophosphatemia, hypermagnesemia, and hyperglycemia. In your neuromuscular junction abnormalities, we see myasthenia gravis, botulism, organophosphate poisoning. In the muscles, we see abnormalities like critical illness polymyopathy, polymyositis, dermatomyositis, and acute rhabdomyolysis. And these tests used to diagnose GBS include spinal tap, electromyography, and nerve conduction tests. Some of the required features include progressive weakness of your legs, ranging from minimal weakness in your trunk and bulbar facial muscles, areflexia, and then some supportive features include progressive symptoms over a large span of time, relative symmetry, mild sensory symptoms or signs, cranial nerve involvement, recovery starting in 2 to 4 weeks, autonomic dysfunction, pain, no fever at onset, elevated protein in the CSF, or sometimes even electrodiagnostic abnormalities. And then in the following features to make a diagnosis, we usually look for sensory level decreasement or loss of your neurological examinations, marked persistent asymmetry, bowel and bladder dysfunction, severe and persistent bowel inflammatory, severe pulmonary dysfunction, severe sensory signs, fever, and CSF pilocytosis. And then in the final slide, we see immunopathologies of GBS, which include your autoimmune disorder, the both cellular and humoral immunity involved. T cell activation includes your interleukin 2 receptor, interleukin 6, tumor necrosis alpha factor, and the interferon gamma. All GBS results from immune responses to non-self antigens like the infectious agents, and those will misdirect the host to the nerve tissue through resemblance of an epitope, and this is known as molecular mimicry. The gangliosides are the neural targets. And then here on the side, we can see a diagram showing us a small recap of all these points.
So, like my colleague mentioned, molecular mimicry is the big portion of Guillain-Barre syndrome. So, this diagram right here will help visualize the immunopathogenesis of Guillain-Barre syndrome. So, what will happen is first, there's some sort of an infection with a pathogen, such as Campylobacter jejuni, which can trigger humoral immune and autoimmune responses that can result in nerve dysfunction and the symptoms of GBS. So lipo-oligosaccharides on the Campylobacter jejuni outer membrane can evoke production of the antibodies that can cross-react with those gangliosides. So then the antigens targeted in the Aman form of GBS are going to be located at or near the node of Ranvier. And then the antibodies bind to induce complement activation, followed by the MAC formation and the disappearance of that voltage gated sodium channel. And then that damage can lead to the detachment of the myelin and cause nerve conduction failure. The macrophages will then invade from the nodes into the periaxonal space. The antigens targeted in the AIDP form are on the myelin sheath. And then the antibodies can then activate the complement, which leads to the formation of the MAC on the outer surface of the Schwann cells, which will initiate the degeneration and the invasion of the myelin by the macrophages. Now, in terms of treatment, so there is no cure for Guillain-Barre syndrome, but there are two types of treatments that can speed recovery and reduce the severity of the illness. So the two types known are going to be plasmapheresis or plasma exchange and immunoglobulin therapy. So these treatments are equally effective. Mixing them or administering one after the other is no more effective than using either method alone. So the medication is also given to patients with Guillain-Barre syndrome in order to relieve pain and prevent blood clots. People with Guillain-Barre syndrome also need physical help and physical therapy before and during recovery. So that may include movement of their arms and legs before recovery to help keep their muscles flexible and strong, physical therapy during recovery to help you cope with the fatigue and regaining your strength and proper movement, and also training with adaptive devices like a wheelchair or a brace to give them mobility and self-care skills. So plasma exchange is the liquid portion part of your blood, the plasma, being removed and separated from your blood. And then the blood cells are then put back into your body, which manufactures more plasma to make up for what was removed. So plasmapheresis can work by basically getting rid of plasma of the certain antibodies that will contribute to the immune system's attack on the peripheral nerves. And then immunoglobulin therapy, what that consists of is basically immunoglobulin will contain healthy antibodies from the blood donors, and it's given through a vein. And then high doses of the immunoglobulin can contribute to the damaging antibodies, and it'll block them, and it'll allow no symptoms to progress for the Guillain-Barre syndrome.
For the recovery timeline, although some people can take months and even years to recover, most people with Guillain-Barre experience a general timeline that follows this pattern. So the first signs and symptoms will lead to conditions that tend to progressively worsen for about 2 weeks, and then the symptoms will reach a plateau within 4 weeks. Recovery will begin, usually lasting 6 to 12 months, and though for some people it could take us up to 3 years. Among adults recovering from Guillain-Barre, about 80% will be able to walk independently 6 months after your diagnosis. 60% will fully recover motor strength 1 year after diagnosis, and about 5 to 10% will have a very delayed or incomplete recovery. Children who rarely develop Guillain-Barre generally recover more completely than adults do.
And lastly, this study basically was designed to define the clinical and diagnostic characteristics of paraplegic Guillain-Barre syndrome with weakness restricted to the legs compared with the classic quadrupedic GBS. So what they did was they collected data from about 490 patients with GBS that were previously involved in some sort of clinical study, and they used that to define the demography, the clinical presentation, the diagnosis, and the clinical course in patients who had paraparesis during a 6-month follow-up. So, what ended up happening was that about 8% of patients presented with a paraparesis without weakness of arms and hands. In 29 patients, or 73% of them, had normal strength of upper extremities, which persisted during the follow up period. So, patients with the paraparesis compared to patients with quadriparesis had a milder form of GBS, with less frequent cranial nerve involvement and less severe leg weakness, despite the fact that the majority of these patients were unable to walk without help. So the median time between the onset of the weakness and the study was about 6 days for patients with the paraparesis compared to the 5 days for the patients with the quadriparesis. And then 50% of the patients with paraparesis presented with arm sensory deficits, and 73% had reduced or absent arm reflexes. And also, the nerve conduction studies demonstrated the arm nerve involvement in 89% of these patients. At 6 months of follow up, 98% of patients with paraparesis were able to walk without help compared to the 81% of the patients with the quadriparesis. There was no association between the paraparesis and like age, sex, or preceding infections. And in conclusion, the study determined that paraparesis is an atypical clinical presentation or subform of GBS, in which the diagnosis will usually be supported by the presence of any sort of sensory deficit, reduced reflex, or abnormal nerve conduction of the arms. And then these are references.
We hope you all enjoyed our presentation. Thank you so much.
Thank you.